You're all good.
Welcome, everybody. This is what has turned out to be an annual talk on BRCA basics. So first of all, I have some disclosures. I don't have any conflicts of interest. This presentation has been given previously for this organization. So you might find an old version of this on YouTube still. I have updated it for this year and it is accurate as of today, October the 15th, 2025. I would also like to tell you that the terms male and female and man and women that I use in the presentation refer to sex assigned at birth, and the term breast is used to describe the mammary gland independent of the gender. And I also acknowledge that I live and work on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. So the outline for the talk is we're going to do a very bread and butter review about genetic basics, because I realize when I see patients, I generally start with, so you have a BRCA mutation. And there's this big assumption that we know that my patients know what we're talking about. And I really don't even know, when you see the genetic counselors, how back to the basics they go. So I do include it in this talk. We're going to talk about the cancer risks associated with the BRCA mutations, how one goes about getting tested, and then the risk management for the cancers that are associated with BRCA mutations. I'm going to talk a little bit about what kind of research is going on currently, and also a little pitch at the end about talking to your family. So to start with, talking about genetic basics, we're going to talk about what DNA is, what a gene is and what genes do, what BRCA genes are and what they do, and then what is a mutation and how do mutations increase cancer risk, and then how are mutations inherited. And in case you've heard other terminology, mutations are also described as pathogenic variants. So DNA is a compound that's made up of 4 chemicals. You don't have to memorize these. There's no test after this, but they're connected to each other in what's called a double helix. So that's a very cool pattern that these chemicals are connected to each other. And the DNA in our body is contained in what are called chromosomes. And these chromosomes lie within the nuclei, or the center of the cells that make up our bodies. And we all have 23 pairs of chromosomes in our cells. And one of each of those pairs comes from each parent. So for every pair, you got one from mom and one from dad. Within the DNA, there are sections that are called genes. And these genes contain the instructions to make proteins that then determine everything about our bodies, how we work and how we function. So for those of you who are more visual, these are our cells. They've got lots of interesting things in it. This is a picture of the nucleus. And then when you enlarge this nucleus, these little X's represent your chromosomes. And within those chromosomes, as I said, there's a DNA, and a section of the DNA is a gene. So BRCA1 and BRCA2 are 2 particular genes, and they're referred to as tumor suppressor genes. And they're called that because they instruct our cells to make proteins that are involved in the repair of DNA. And our DNA gets damaged naturally over time as we age, but also from outside sources like radiation, chemicals, smoking, and all sorts of things like that that we know are bad for us. And the problem is that if you can't repair damaged DNA, this can lead to cancers developing. So what's a mutation or a pathogenic variant? That's like a spelling mistake in the gene. Remember I said there were these chemicals and they might be ACGT, and a spelling mistake makes it GATC. And when you have a spelling mistake like that, it means that your gene can make a protein that is either not working normally or it doesn't make the protein at all that it was supposed to. We have 2 pairs of genes. If they're when you have normal ones, if one of them gets damaged, there's a backup system to make the normal proteins. When you have a mutation, one of your pairs of genes doesn't work properly. So then if the other one gets damaged, you may lose the ability to make these DNA repair proteins. And just for some reference, these are not common mutations. These occur in the general population, we think in about 1 in 400 people. So that's our double helix again with the genes making a normal protein, and with the gene that has a mutation, either an abnormal protein or no protein at all. So how are these mutations inherited? Well, when a sperm or an egg forms, it actually only has one of each pair of the chromosomes. So our normal cells have 2 pairs, eggs and sperm only have 1 pair. And then when the egg is fertilized, the chromosomes from the egg match up with the chromosomes from the sperm to make a full set. So an abnormal gene can come from either the sperm or the egg. So you can inherit the mutation from either parent. And similarly, if you have a mutation, there's a 50% chance that you will pass it on to your child because your egg or your sperm may have the mutation in it or it may not have the mutation in it. So again, this is just a picture. So this is a man and a woman here, and this man has a mutated gene, right? He's got a pair of genes. One of them doesn't work properly, and the wife here, the female partner, has 2 normal genes, and they have children. And each of these children has a 50% chance of getting the mutation. So here, there's a boy who got the mutation, there's a girl and a boy who didn't, and then there's a girl who got the mutation. So you can get it from either parent, and you can pass it on both to daughters and sons. Now, we're all focused here on hereditary cancer, but it's important to realize that most cancers are not hereditary. So we believe that only about 5 to 10% of all cancers that occur are specifically due to a gene mutation that's inherited within the family. What's special about this situation is that with hereditary cancers, there's a very high risk for people who carry these gene mutations to get cancers compared to people who don't. We think about 10 to 20% of cancers are what we call familial. So there's multiple genes involved, multiple factors, and there may be some increased cancer risk. But the majority are just what we call sporadic. So they are occurring not because there's a genetic problem, but because of chance or because of environmental exposures. And that's the cancers that affect most people. So when we see people, say, as physicians in a family practice, we have to think about who out of these 400 people that we're seeing in a week might actually have a genetic mutation and need to be assessed for that. So there are what I call here red flags. In the medical world, we call these referral criteria. So things that would lead to a person being referred to the hereditary cancer program. So if we see a person under the age of 35 with breast cancer, if we see a woman who has a breast cancer that is not sensitive to any hormones, that's called a triple negative cancer. If we see a woman who has ovarian, fallopian, or peritoneal cancer, if we see a woman who has had breast cancer and then gets an ovarian cancer, or the other way around, so both cancers in the same person. If we see a family where multiple people on the same side of the family have cancers that are known to be related, like ovarian and breast, for example. And then, just to not be focusing all on women, we also know that male breast cancer is uncommon in the absence of a genetic mutation. We worry about metastatic prostate cancer, so that's prostate cancer that's spread. And the reason that that's a concern is because prostate cancer is typically a pretty called indolent cancer. It grows very slowly. Most men who have it will die from something else before they die of their prostate cancer. But I'll talk more about the nature of prostate cancer in BRCA carriers is more aggressive. So if we see a metastatic prostate cancer, we want to know if that's associated with a mutation. And we also are concerned about pancreatic cancer. So people who have any of these problems can be referred for genetic testing. And we're also aware that there are higher risks of BRCA mutations in certain ethnic groups. So if we saw someone from a particular ethnic group who maybe didn't quite meet all of the criteria, maybe they have breast cancer and they were 38 years old, that would still be someone that we would be concerned about. So what are the cancer risks with a BRCA mutation? So this chart has that BRCA1 and BRCA2 on the top, and no mutation is the general population risk. So the most common cancer that occurs with BRCA mutations is female breast cancer. These are the average risk numbers. There's always a range. They change, depend on other factors, and I'll talk about that a bit, both in this talk, but also in another talk later this year. But generally, the average, what we call lifetime risk for breast cancer with a BRCA1 mutation is 72%. And that's compared to 12.5% if you don't have a mutation. When we talk about lifetime risk, that means if you're 25 years old now, what is the chance that you would get breast cancer by the time you were 80? So if there was 100 women like that, 72 of them would get breast cancer by the time they were 80. For BRCA2, it's 69%. Male breast cancer is uncommon. You can see in the general population, less than 1 in 100 men. It's mostly increased in BRCA2 at 7% and slightly in BRCA1. So still not common compared to female breast cancer, but you can see it's much, much higher than if a man does not have a mutation. The other common cancer associated with BRCA is ovarian cancer. You'll notice on the previous slide, I said ovarian, fallopian, peritoneal. This is now considered a group of cancers, but we call it ovarian cancer for simplicity. And the risk in BRCA1 is a little over 48%. In BRCA2, it's 20% compared to 1 to 2% in the general population. Now, you might also hear BRCA referred to as hereditary breast and ovarian cancer. So that's sort of hereditary breast and ovarian cancer syndrome. And we're trying to move a little bit away from that because it's not only breast and ovarian cancer. So in men, there is an increased risk of prostate cancer, particularly with BRCA2, but also with BRCA1. Much higher than in the general population. There's very wide ranges reported in the literature because a lot of people don't get tested. So unless you're actually testing everybody who gets prostate cancer, it's hard to actually know for sure what the numbers are. But we do know that there is an increased risk, particularly with BRCA2. There's also an increased risk of pancreatic cancer. Again, mostly with BRCA2 at 5 to 10% lifetime risk compared to just over 1% in the general population and less than 5% in BRCA1. And in the last column, I have other cancers. So these are cancers that are giving us a little blip on the statistics scale. And the reason that we don't know 100% about this is if you think about when these genes were first identified back in the late 1990s. They were found by doing DNA analysis on people who came from families that had very strong histories of breast and ovarian cancer. And unfortunately, in those families, a lot of the people who were affected by cancer died. So what you would see in that family is the manifestation of the most common cancers. Now, because we're better at this, we have better screening for some of the cancers, better treatments. better preventative surgery, people who have BRCA mutations don't die. And so we have a larger population that we can follow for much longer. And then we can start to see cancers that are just a little bit increased, but not enough that we pick them up right away. So it's a field that the longer we follow people and families, the more information we're going to have about cancer risks. So how does one go about finding out if they have a BRCA mutation? So the most common method in British Columbia is by being referred to the BC Cancer Hereditary Cancer Program. And you can refer yourself or your physician can refer you. And your referral forms, when you complete them, will be reviewed. And now they have what's called an online portal. You get an invitation to that portal, you work your way through it, and then you kind of get a open door to go forward. And if you get through that door, then you'd be sent a requisition to have a lab test done that you could take to your local lab. The results would go to the hereditary cancer program. And then if your test was positive, you would be contacted to have an appointment arranged to discuss that with a genetic counselor. The reason that I said there's a door is because there is review of these. So some people, for example, don't meet the strict criteria, but they are people who need to be seen. So it's not just a black and white referral process. The other way is through private pay testing. So there are a number of labs, particularly in the United States, but also some in Canada, that offer genetic testing for a wide variety of things. So cancer testing, heart disease testing, and if you pay them, you can have this testing done. They usually have some kind of built-in genetic counseling system involved as well. We don't recommend what's called direct-to-consumer testing. So that's things like 23andMe, which I think is now out of business. But the problem with those organizations is the quality control was not as good. They weren't necessarily as critically licensed facilities. So when we had abnormal results, we always had to repeat them. And then some were true and others were not. So if you got a result that's saying that you didn't have the gene, you still might have the gene, right? The gene mutation. What's happening more often now is something that we call mainstreaming. So that's when currently, if you had a cancer diagnosed and were seeing a doctor, a cancer specialist for the first time, and they took your history and about your family, they could actually order the test themselves for you rather than having to refer you to the hereditary cancer program and go through that process. And this has been a very important new route because it really shortens the timeline. And there's a lot of new treatments now for cancers that are specific for people who have BRCA mutations. So it's important that the cancer doctors know whether their patients have a mutation or not. So what happens in BC if you're found to carry a BRCA mutation? So we have in BC what's called the Hereditary High Risk Clinic, and patients are referred to that clinic from a genetic counselor typically. We see women and not men, and the reason is when I explain what we do with people, why we see women and not men. And we see people who have either a confirmed mutation, but also those who are at 50% risk and still untested. So sometimes a young woman, for example, might know that her father carries the mutation. So she has that 50% risk, but she doesn't want to know yet. But she still wants to access the screening and counseling that we provide. So we do still see those women as well. We also accept referrals from oncologists, so from cancer specialists. If a patient has had cancer treatment and all of the follow-up that the oncologist wants to provide is finished, rather than sending you back to your family doctor, they can refer you for ongoing follow-up at the high-risk clinic. We provide services to all of British Columbia and the Yukon territories, and do these either by telephone for people who live more than an hour away from Vancouver, or by in-person consultation if people live locally. And then we provide annual follow-up as well. When you're either way with the consultation, we take a full medical history so we know who we're talking to. If we're being seen in person, we do a breast exam. We review the risks associated with the mutation, talk about all the management options that you have, make a plan for a starting point in your care. We arrange any imaging that you need, any surgical referrals that you need, and as I said, we follow you. And currently, we follow women until, if they keep their breasts, until they're 75 years old. We discharge people once they've had mastectomies because much of the work that we're doing is around the breast screening. So when I talk to people about their management of their breast cancer risk, there's three things that we talk about. One is about increased screening. The other is about surgical prevent risk reduction. And the last is about medication for risk reduction. And I'm going to talk about each of those. So if a woman does not have a mutation and doesn't have a family history of breast cancer, currently in British Columbia, the recommendation is that you have a mammogram every other year from age 50. You can access the screening program from age 40 in BC. If you have a mother or a sister or a daughter with breast cancer, then you are able to get your mammograms every year instead of every other year. If you have a BRCA mutation, we start much earlier. So we start annual mammograms from age 30, and we continue them as long as you're in good health otherwise. And I just want to explain a little bit about different kinds of mammograms. So we have in BC something called the screening mammography program, and that's something that women can refer themselves to if they're over 40 years age. And you get a standard mammogram, and that works for everybody, and that's what we use for people who are otherwise well. The exceptions are if you have had breast implants put in, there's a particular type of imaging that needs to be done so that we can see the breast and not just the implant. Or if you've had a previous breast cancer or other abnormality that's being investigated, then you need to have what's called a diagnostic mammogram. The basics of these two images are exactly the same. So some people think, a diagnostic mammogram is better than a screening mammogram. It's not. The only difference is that with a diagnostic mammogram, they can also do additional imaging or additional views to allow a better look at an area that they want to look at. Okay. We do mammograms because mammograms do show things that MRIs don't. And I will show you some pictures of that in a moment. In addition to the mammograms, we offer an annual breast MRI from age 25 to 75. So MRI is very sensitive to detecting cancer. So it'll pick up about 96% of cancers, which is much better than a mammogram. But as I mentioned, some things do show on mammogram better than MRI. There's also an issue with false positives. So false positive means we see something, but it isn't cancer. So that happens quite frequently with MRIs. I tell patients like about 20% of the first MRIs that we do have something on it that needs more tests, which of course is very stressful to go through, which turns out not to be anything. That tends not to happen as often with mammograms. We recommend that women have an annual clinical breast exam. If they're not local, then they see their primary care providers for that. Women are supposed to be breast aware from the age of 18. There's not a big push anymore for doing a monthly breast self-examination, but I think it's important for women to examine themselves in some way. So I usually encourage people when they're in the shower and they're washing themselves to slow down when they're washing their breasts and just pay attention whether they feel anything different on one side compared to the other. There's lots of good studies about why do we do screening. So there is evidence that if you have this screening, follow this screening protocol compared to not having screening, even though this isn't going to prevent you from getting a breast cancer, you are more likely to survive your breast cancer than if it was not detected on screening. So if you just waited until you found a lump. So I just wanted to show you some pictures of, this is mammogram. So this is a breast squish down, and just a couple of different pictures of lumps. So this is a breast cancer. If we magnified this, we made it larger, we would see that the edges are a little bit irregular compared to a cyst, for example, which tends to look just like a smooth round circle. This is a more obvious, the one in the center here, it's got an even more irregular margin. And over on the right of your screen, these are calcifications. So in some breast cancers, calcifications form within the ducts. This isn't related to how much calcium you have in your diet. This is just the nature of what's happening to the cells. And these calcifications are much easier to see on mammogram than they are on MRI. And that's why we do the two together. So the ability to detect cancers is better when you do mammogram and MRI together than when you do either just mammogram or just MRI. This, on the other hand, is a picture of breasts in the MRI machine. And in the analysis of MRIs, they use something called computer-assisted diagnostics. And you get an injection of dye that goes, that's taken up in a certain pattern by different tissues. And the computer program color codes that. So red spots are bad, blue is not bad. So this makes it very easy for us to look and say there's something not good going on there. So that's one option. And basically anybody from the start point that we see is going to start with screening as part of their care. Women then have the option of having preventative surgery, so preventative removal of breasts, and they can choose to have reconstruction with that or not to have reconstruction. It's completely a personal choice. If they want to have reconstruction, there's a number of different ways that breast can be reconstructed, and we will talk about that in future talks. That surgery reduces the risk of developing breast cancer by more than 90%. So it's not 100% because it's not technically possible to guarantee that you remove every single breast cell when you do this operation. And if you leave only one behind, it could be the one that goes bad and you develop a breast cancer. However, after the surgery, you don't need to have mammograms or MRIs anymore. We ask you to see your physician for a physical examination of the chest every year, and you pay attention to them. And when and if new cancers occur, they're like little tiny hard peas under the skin. I like to remind women that once you've had this surgery, you're not a high-risk patient anymore as far as breast cancer goes, though. So you remember that the general population with breasts had a 12.5% cancer risk. You've reduced your, say, 70% by 90%. So your risk is going to be lower than the 12.5. If a new lump is felt, then you need to have imaging done. Usually we start with an ultrasound to see what that is. When we talk about screening versus surgery, again, the primary benefit of the surgery is prevention. So it's reducing the risk of getting cancer, right? Whereas screening is about early detection. Unfortunately, there's not a lot of evidence that surgery has a big impact on survival. So I tell people if I took 100 women with a BRCA mutation and they chose to have screening, and another 100 women chose to have surgery, and we followed them until they were 80 years old, there would be about the same number of women in each group still alive. And that's because we have very good screening for breast cancer and we have very good treatment for breast cancer. There's been a number of papers published about mathematical modeling. Like if we take your risk of getting breast cancer, the probability that you'll find it early, the probability that you'll be cured, these models suggest that there should be a small survival benefit in young women. So survival benefit means that if we followed those two groups, more of the women in the group that had the surgery would still be alive than in the group that didn't. Up until very recently, there's never been any clinical studies to confirm that survival advantage. But in the last couple of years, there have been some publications put out with benefits around 2%. So it's not a big survival issue. It's really about what experience are you prepared to live through going forward in your life. And we do know that because of the types of cancers that occur in mutation carriers, more than half of our patients do need chemotherapy, even for those very early cancers that we found on screening. So there is a third option. If you choose to keep your breasts and you're having the screening, you can also take medication to reduce cancer risk. And this is called chemoprevention, even though it's not actually chemotherapy. So there are a number of drugs that in the general population have been shown to reduce the risk of developing breast cancer by 50% if you take them for 5 years. They reduce the risk only of hormone-sensitive cancers. These drugs haven't been specifically studied in mutation carriers. So the data that we have was from studies on women who had bad family histories, or they had biopsies that showed precancerous changes, and half the woman took a drug and the other half took a sugar pill, and we followed them for 5 years and we had the 50% reduction. We do know that the drugs work also in mutation carriers, and we know that because in women who are mutation carriers that get a breast cancer and they choose not to have mastectomies, so they still have another breast, like the other side that hasn't had a cancer already, they have the same, if they take one of these drugs, the same reduced risk of getting a new cancer on the other side than is demonstrated in the literature in the general population. A little bit lower for BRCA1 than for BRCA2, because the BRCA1 patients more often get cancers that are not hormone sensitive. So there's a number of different drugs. They all have different side effects. Some of them can only be used postmenopausally. So normally when I see patients in the office, we have some written information sheets that we can provide that you can look at the drug options and see if that's something that you're interested in doing or not to reduce your cancer risk if you don't want to have surgery. In this particular talk, I'm only going to talk a little bit about things other than your genes. We are doing another talk later in the year about risk modifiers, but I wanted to talk a little bit just about pregnancy and nursing because it's a question that comes up quite frequently. So this first is talking about how pregnancy affects breast cancer risk. So this topic is a bit all over the map, and I review it every year, and it's not getting a whole much clearer to me, even though I read it every year. I can say, so it does appear for BRCA1 that being pregnant more than once reduces breast cancer risk. And the more pregnancies you have, the further the risk decreases up to about a stabling of about a 50% lower risk. For BRCA1, it appears that really early pregnancies are not good. Fortunately, that tends not to be a very common problem in our current population. So having a later age at your first pregnancy reduces risk. But there's also some data that suggests that only having one pregnancy might increase your risk. So in my opinion, this is a little crazy making because you don't know what you're supposed to do. And I just tried to explain to people that you have a high risk, right? So no matter what you're going to do, it's not going to make it go to zero. But people should be there. When we're going to get more onto the topic of nursing, there's balances to things that might increase risk versus not. And again, going back to what I talked before about cancers that might be a little bit, it's when you have years and years of publications that still have a may beside it, it means that if this may increase risk, it's not going to be like quadrupling your risk or doubling your risk. It's going to be a small amount. For BRCA2, pregnancy might, again, may increase risk, except if you have more than one child before you're 40, or if you have more than 4 children. So one of the difficulties with this is when we have scientific results, you're trying to understand, how does this make sense? You have to have a rational reason why it would affect one pregnancy, not more pregnancies, your age, and we just don't have that yet. But this is what the state of the art is at the moment. Breastfeeding, fortunately, is much simpler. There's this data has been published previously, but there was a 2025 article from a big group in Toronto that publishes tons of stuff on this topic. And breastfeeding reduces breast cancer risk in BRCA1 carriers. They found that if their population had ever breastfed, they had a 25% lower breast cancer risk. And if they breastfed more than 20 months, they had a 50% lower risk. And as I said, that's why it complicates things, because if you're talking about your breast cancer increasing your risk, but then nursing is going to decrease it, looking at these big numbers, I think that it's likely that your breastfeeding benefit will knock out any small increased risk you might have had from a pregnancy. Unfortunately, breastfeeding has not been found to decrease risk for BRCA2 carriers. No explanation given in the literature as to why it would be different for one versus the other. So what about if you get breast cancer? What are your options? So traditionally, and this has certainly been my experience in the clinic, if one of our patients got breast cancer, I'd say 98% choose to have bilateral mastectomies because you have this fear of it occurring on the other side. So there is a higher risk of getting breast cancer on the other side in mutation carriers, particularly if you got your breast cancer before you went into menopause, so higher compared to the general population. And there might be a small survival benefit to having mastectomies for treatment of your breast cancer if you're under the age of 40. And I put a little caveat in the brackets there about statistical difference versus clinical relevance. So in this particular paper, they showed that women who'd had, that the survival for women who'd had mastectomies was 1 year longer than those who didn't have mastectomies. So 1 year is a lot of time, but it's not like 20 years. Some women may choose to have mastectomies for this possible 1 year survival advantage, and other women will not. The other thing is that the treatment that we give for breast cancer, like tamoxifen, one of the drugs that we talked about for cancer prevention, for cancer risk reduction, or removal or suppression of ovarian function, they also reduce breast cancer risk and improve survival. So what that means is, while most women choose to have mastectomies, and I must say in my experience, most surgeons and most oncologists will tell you that you should. In fact, you don't have to. You may experience a cancer on the other side at a higher risk than the general population, but we're going to do other things that will also reduce that risk. So just like the preventative surgery in the first place, this is still a personal choice. And it's especially important, I think, to consider age as an issue. If you're under 40, there might be an advantage. If you're 69 years old, you're not going to be more likely to be alive when you're 80 if you have mastectomies or if you don't, because your risk, all these risks that we have are lifetime risks, or risk at 10 years or risk at 20 years. If you have a heart problem, maybe that's going to be your biggest problem in 20 years, and not whether you have a tiny little new cancer on the other side. So what about male breast cancer? As I mentioned, the risk is increased compared to the general population, but not super high, but 7% for BRCA2. The recommendation is a physical examination by a physician or nurse practitioner beginning at age 35, and that men pay attention to their breasts or chests. So if you felt a new lump under it, or you looked like you had a sore on your nipple, then that would need medical attention. There's some controversy in different guidelines about whether there's a role for mammography in men. Now, a lot of men don't have enough tissue to have a mammogram, but if we're talking about if a man did have enough tissue to have a mammogram, is there a benefit to doing them or not? And we don't recommend them routinely in men, really, because the risk is still, when you think about it, the risk of a man getting breast cancer with the BRCA2 mutation is still like half the risk of breast cancer in a woman in the general population, where we only have some evidence of a benefit for screening. So when we do screening, we want to show that we're not doing it just out of interest. We're doing it because we're going to find something sooner and the treatment is going to be different. So ovarian cancer is a very different story than breast cancer. So we do not currently have any effective screening for ovarian cancer. Studies have been done looking at blood tests, tumor markers, ultrasound. We are just not able to pick up ovarian cancer early. And unfortunately, it tends to grow not to form a lump, which is why it's hard to detect. It grows very silently for a long time. And currently, if you wait for people to have symptoms, most women have very advanced disease. And then our cure rates are not as good as they are for breast cancer. So because of that, we do recommend preventative surgery. Now, taking the birth control pill for more than 5 years does reduce the risk of ovarian cancer by about 50%. But if we go back to the numbers, if you had like a 48% risk of developing ovarian cancer in your life and you reduced it to by 50%, you're still looking at a 24% risk of developing ovarian cancer in your life. So it's not super high. I find in my practice where this comes into play more is in some of the other genes that are associated with lower breast cancer risk in a woman who is already 75 years old. You're getting to a pattern where their risk might be low enough that you're not going to recommend an operation. So currently, the surgery that we are recommending is preventative removal of fallopian tubes and ovaries. And that's recommended between the ages of 35 and 40 for BRCA1 and 40 to 45 for BRCA2. The ages are different because of the typical starting age of onset of these ovarian cancer is different in the two different genes. And we do remove tubes and ovaries. And we have evidence now that what we think we've been calling ovarian cancer all these years is actually probably starts in the fallopian tube. So that's why it's tubes and ovaries. Unlike breast cancer, there is a survival benefit to having this surgery. So if you have this surgery, your chance of dying is reduced by 70%, so big benefit. And that's both because it reduces the risk of developing ovarian cancer, but also if you're premenopausal when you have the surgery, which most women having it at the recommended ages would be, it also reduces the risk of developing breast cancer. Like the mastectomies, though, it's not 100% perfect. So there is a small, and I put the numbers there, so much less than 1% per year, but there's a risk of something that we are still calling primary peritoneal cancer. So that's a cancer that looks just like ovarian cancer, except the woman's tubes and ovaries are already removed. And that's the risk that we see if at the time of surgery, the pathology specimen is reported as completely normal. So they don't see anything on the review of the specimen that looks like anything precancerous. And unfortunately, we don't have screening for that either. We're If you have your ovaries out and you're premenopausal, it's going to put you into menopause. That is bad for you at 35 or at 40 years old. It's bad for your bones. It's bad for your heart. It's bad for your quality of life. So we do recommend hormone replacement therapy. So it's like estrogen and progesterone to the age of natural menopause. And that is for all women unless they've had a hormone sensitive breast cancer previously. Um, we ask the family physicians to monitor bone health with bone density, heart health by making sure you don't smoke, you don't have diabetes, your blood pressure is under control, your cholesterol is under control. So you don't want to contribute at all to heart problems. Hormone replacement does not increase breast cancer risk. So it is perfectly safe to take hormone replacement, and you should, because it's bad for you if you don't. I will talk a little bit more about research later, but there is research going on about ovarian cancer, which we're calling tubes first. So we believe that ovarian cancer is actually fallopian tube cancer. And starting, I'd say about in 2014, the gynecologists started recommending to other gynecologists that if they were doing an operation, like to remove a woman's womb for bleeding or fibroids or something like that, they would actually take the fallopian tubes out as well. Previously, they just left them there with the ovaries, but now they would take them out. And what studies here and in other places have shown that in the general population, this preventative tube removal is reducing the expected occurrences of ovarian cancer in the general population between about 40 and 77%. But the problem is we don't yet know how much of a benefit you get if you're a mutation carrier and your risk is so much higher. So those are the studies that are going on. As I said, I'll come back to them towards the end of the talk. Interestingly, pregnancy does also influence ovarian cancer risk in the general population. Having had pregnancies reduces the risk of ovarian cancer. In BRCA1, there are some studies suggesting that it decreases risk. Maybe more pregnancies might be better, but a little bit very inconsistent findings with BRCA2, with some studies saying it increases it and some studies saying it decreases it. Nursing, again, is simpler. So ever breastfeeding is associated with a 23% lower risk of developing ovarian cancer. And the benefit increases until for up to about 7 months when you're at about a 30% lower risk, and then it doesn't get better with more nursing. And same for BRCA1 and BRCA2, and that's published by exactly the same group that published the other study on the effects in pregnancy. So pancreatic cancer, I mentioned it's about 5 to 10% risk in BRCA2, less than 5% in BRCA1. The most important thing that you can do is not smoke. Smoking increases risk of pancreatic cancer. Drinking also increases risk of pancreatic cancer because alcohol can cause something called pancreatitis, which is inflammation in your pancreas, and recurrent episodes of inflammation in your pancreas is associated with increased pancreatic cancer risk. Our recommendations differ for the different genes and also whether or not there's a family history of pancreatic cancer. So we recommend screening for diabetes. It's a blood test called a hemoglobin A1C. And for a BRCA1 carrier without a family history, that's recommended every 3 years from age 40. And for BRCA1 with a family history in a parent, or aunt, uncle, sibling, child, or any BRCA2 with or without a family history, because the risk is a little higher. We recommend the blood work be done every year from the age of 40. And as an aside, for all these age recommendations, we always say, or 10 years younger than the youngest member in the family affected with that problem. So, for example, if your father had pancreatic cancer at age 45, we would be recommending the screening starting for you at age 35. Now, obviously, diabetes is very common in the general population, right? So if somebody is a BRCA carrier and they have a new onset of diabetes, though, we do imaging of the pancreas then to make sure that it's just diabetes and it's not because there's a mass. And if somebody, for example, if I'm seeing somebody who's already, been diabetic for several years, then it's really if all of a sudden the diabetes becomes out of control and there's not another explanation for why that might have happened, they should have imaging of the pancreas. For patients for BRCA1 where there's a family history, BRCA1 or BRCA2 where there's a family history and a close relative, we add to the blood work also having an MRI of the pancreas alternating every year with what's called an endoscopic ultrasound. We start those at age 50 again, or 10 years younger. The endoscopic ultrasound is when a specialist puts a scope through your mouth into your stomach that has an ultrasound probe on the end of it, and they're able to look at your pancreas through your stomach. Currently, just new this year, for BRCA2 carriers without a family history, there is an option of seeing a specialist for this enhanced screening. We don't have as much evidence that there's a benefit for it, so it is an optional personal choice. The difficulties are there's often abnormalities found, and then you have to go through lots of additional follow-up to make sure they are nothing. So I mentioned earlier about prostate cancer. Its behavior is different in BRCA carriers than in the general population. So prostate cancer in the general population tends to grow slowly, be not very aggressive. Typically, it's an older man. With BRCA, it tends to occur much younger, usually what's called higher grade. So it's a more aggressive looking under the microscope, and it is associated with a poorer prognosis, so higher chance that it will spread. So the recommendations, the current screening that we have for prostate cancer is having a rectal examination. So the doctor examines you with a finger in your bum to see if they feel a lump on the prostate gland. And that should be done once a year. And also a test called a PSA, which stands for prostate-specific antigen, and that's a blood test. Unfortunately, it's not covered by insurance for people who don't already have prostate cancer, but it's only about $35 or $40, so not hugely expensive. The recommended start age is a bit younger for BRCA2 than for BRCA1. Just going to put this up sort of as a single slide of things that we know are bad for us. So this is like general population data about things that appear to increase cancer risk. And I will talk about this more, I think it's in December. So smoking, drinking, being overweight, particularly in women postmenopausally, is associated with increased breast cancer risk in the general population. Not being physically active, eating a bad diet. Some studies showing that vitamin D deficiency is associated with increased cancer risk. There isn't any studies that show that vitamin D supplementation reduces cancer risk unless you were deficient in the first place, and getting excess sun exposure. So there is very little data about this specific to mutation carriers, and as I said, we'll talk about that more in the future. But we do know that your genes are not written in stone. How your DNA, how it manifests itself is influenced by the environment that it's in. So we don't really have a reason to expect that these things aren't bad for you if you're a mutation carrier. And the other thing is that you're still entitled to get the same things that the general population gets, right? So, for example, let's say lung cancer is not related to BRCA. Well, smoking causes lung cancer. So you still have that as an issue, whether you're a mutation carrier or you're not. So how do you know what's happening with research? So there's a couple of websites that are informative. So Women's College Hospital, which is a hospital in Toronto, has on its website the studies that they're undertaking. The group that I mentioned from Toronto that's publishing all these papers, they're at Women's College Hospital. So this website isn't only about BRCA studies, but it does have the BRCA studies available. And then the other site is FORCE, which is called Facing Our Risk Empowered. This is a US-based organization, and you can go to their website and it shows you all of the cancer trials that are available. But they are US-based, and you can look at a site and it tells you like what hospitals are doing this. And unfortunately, you can't enroll in a US study unless you're prepared to actually go there for whatever testing needs to be done. So generally, unless a study is open in Canada, or preferably if everybody online here is from BC, in BC, it's not really something that you're going to be able to access easily unless you have enough money to fly back and forth on a regular basis. But I thought I'd let you know what was out there anyway. So first, under the risk factor study. So the reason that there's all these publications from this group in Toronto is that they started back in like 1997 collecting data on all of their patients and have continued to do so. So they have thousands of patients now that they're followed, and they're able to look at what happens to them and things that influence risk, pregnancy, nursing, all of that stuff. They have that information. So and anybody can enroll in this because it's a data collection system. So it's a long-term risk factor analysis study. And this is the email address to make inquiries about that study. There's then a lot of studies about prevention, and I put in bold here the ones that are in Canada. I put the other ones down because I do hear, a lot of concerns from my patients that not enough research is being done about preventing these cancers, and why isn't more research being done about preventing these cancers? So this is just to show you that there is research being done about preventing these cancers. So in BC, these are the trials, and this one's in Toronto, but the first three are open in BC. So the first two, the SOROC trial and the TUBA-WISP trial, are trials looking at removing the fallopian tubes and delaying removing the ovaries for ovarian cancer risk reduction. So if you just remove the fallopian tubes, you don't go into menopause. So that's the benefit of doing it this way. And what they're trying to see is whether women are getting ovarian cancer after they remove their fallopian tubes before they have their ovaries removed. So that'll give us a sense of how good is just removing the fallopian tubes at reducing the risk of ovarian cancer. There's another study in BC looking at identifying in a population, in one high-risk ethnic group, identifying carriers. So at the beginning, I talked about the red flags. How do we identify people who might carry a mutation where we can do something for them to screen or prevent their surgery? And we have red flags. The problem is that some studies have been done looking at higher risk groups, and they show that only half of the people actually have any of those criteria that were on the list of things that would make you think they have something. So we're missing 50% of a population. So in this study, anybody in this ethnic group can have BRCA 1 and 2 testing as long as they're an adult. So we're trying to see how many people we're finding that wouldn't meet the criteria otherwise. BC also has what's called a parent of origin study. So as I mentioned, you can get your mutation from either parent. So let's say you're 35 years old and you get breast cancer, you meet the criteria you're testing, you're found to carry a BRCA mutation. There's no cancer that you know of on either side of your family. You don't know which side of your family it came from and which side should have testing done. So they've discovered a way to determine which side of the family it came from. And the advantage of that is instead of everybody having to be tested, it focuses on one side of the family in communication of risk and further testing. There is also a study in Toronto looking at what's called the value of cascade testing. So cascade testing kind of links to this parent of origin. Cascade testing, like cascade is like a waterfall. It's you find one person and then the number of people that you test subsequently that are related to that person. So that's called cascade testing, and we don't do very well at it. So we're forever looking at ways to make that system work better. So we make sure that everybody who is at risk knows that they're at risk and is given the opportunity to be tested. So they have a study out of Toronto doing that. The US has more studies that are more interventional, taking medication for risk reduction, vaccines for risk reduction. So those are called clinical trials. So there are a number of those going on in the US, not yet with results. And they take time to get the results because it takes time to get the cancer. So you say give somebody aspirin for 5 years, then you need to follow them for 20 to see what happens and how much you may or may not have reduced the risk. There's also a number of studies looking not at prevention, but at early detection. So again, the first two at the top are open in BC. So one is the CHARM study. The CHARM study is a study that looks at what's called cell-free DNA. So tumors release DNA into our bloodstreams, and that can be detected on blood tests. So in this study, half of the patients are having blood work 4 times a year to look for cell-free DNA. And if the test is positive, then they have intensive investigations to try and see if we can find a cancer that hadn't been found on the routine screening they were having already. The PRECEDE study is really just tracking screening outcomes. So it's for patients who have an increased risk of pancreatic cancer. They're collecting data and screening outcomes to help us better understand how beneficial the screening that we're offering is or isn't. And then the ones that are not in bold are studies in the US looking at ways to detect all of the other cancers. Uterine washings for ovarian, a number of different things for pancreatic, and a number of different means to detect prostate cancer. And then there's also some studies looking at different ways of doing the imaging. So if you have a breast MRI, you're in the machine for half an hour. There's different protocols that might shorten the length of time with just as good results. So we might be able to get more people, more access to MRIs in a more timely fashion than we currently do. And then there's new therapies. So there are some good news about being a BRCA carrier. And the good news is that there are drugs called PARP inhibitors, which work for BRCA-associated cancers. So if you have ovarian cancer and your BRCA mutation, you are treated with PARP inhibitors in addition to your standard chemotherapy. And these drugs are associated with an improved survival compared to the previous chemotherapy that we were using alone. So there's a number, once we understand scientifically what the pathway is for how BRCA works, they can develop specific ways to stop things from happening down the pathway. And that's a lot of what the investigations are as far as chemotherapy and other drugs for the treatment of ovarian and breast cancer. And then there's also some studies going on looking at managing the side effects of the things we do. So how can we, best manage post ovarian surgery hot flashes, for example, which really are very miserable. And that's particularly, for example, if we have women who have had a hormone-sensitive breast cancer and ideally should not take estrogen, we're looking for other medications to use to control their symptoms. And this is my last content slide. So this is about talking with your family. So most patients are comfortable with talking to their siblings, to their children, once their children get a little bit older, to talking to their parents if they're the child that found out that they had a mutation. The problem is with families where there's maybe you're not in touch with your father's side of the family, there's been a divorce, something like that. And also communicating with extended families. Like, let's say both your parents have passed away, but there's living cousins, aunts and uncles, things like that. It is really important that everybody who might be at risk is told that they might be at risk. And it's important because if they aren't told, they can't prevent their cancer. And if they get cancer, they could die. So if they're not informed, they could die. We recognize that it's hard to call up your second cousin once removed that you haven't spoken to in 3 years, to talk about this. So we do offer now what's called shared decision support. So if you're not comfortable contacting this person, the Hereditary Cancer Program will contact the person on your behalf. It's anonymous, so we don't say Susan has a BRCA mutation. It would be a member of your family has been identified to have this mutation and you are at 50% risk, that sort of thing, to try and improve this cascade testing. Because right now, even if we just look at people in BC, so those are the ones we would know, we're only at about 10% of potential relatives that actually come forward for testing. So it's pretty bad. How about keeping up to date? I forgot I had another slide because I added this one. So this is a very fluid field. Recommendations change every year, both as far as risks and also as far as risk management. We do have a websites that through BC Cancer, both for the Hereditary Cancer Program and the High Risk Clinic. And there is a plan for the Hereditary Cancer Program to start putting all of the updates onto their website because currently they update basically by mail out with a bit of a delay in that. For patients in the high risk clinic that we are following, we do direct notification for any new recommendations that would change what we're currently doing for people. People who haven't been seen at the high risk clinic or have been discharged from the high risk clinic, you do get an annual email survey from the Hereditary Cancer Program. It's part of what's called the Hereditary Cancer Follow-Up Initiative. And it has a number of questions about what screening you're having, things like that. And if you respond to the survey and your answers show that you're not following the screening recommendations, then you would be contacted. Or if you ever just write, I'd like to be updated on what's going on in your survey, then one of the genetic counselors will reach out to you. One thing that doesn't require you to do anything is this Force, that US site. You can actually sign up for gene-specific newsletters. So your BRCA, you sign up for the BRCA newsletter, you'll get their newsletter acknowledging it's US specific, but if there's big changes, it's going to come out in that newsletter. And now we're open for questions. So we're going to stop the recording, yeah?
That's right. Thank you. We will stop the recording and we'll